This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best.
So on the other side of the divide, then what about those chronic cases where we know that the joint has got osteoarthritis? There isn't any instability. Because of this instability, such as a cruciate ligament rupture, then that's a surgical situation. Let's say we've got a stable joint that has OA, chronic, and we want to use an orthobiologic. What are we going to do in that situation?
The orthobiologic there, I think, would be your stem cell. You've got an environment now that is not catabolic, it is stabilized, and the joint to a certain degree is able to balance the situation. The synovium to a degree is doing its job. We've got to take into consideration the environmental factor. A stabilized patient could destabilize quite quickly. So we do need to keep these patients under control, whether it's really strict exercise regime, home environment. Those things are hugely impacting on our next bit. But I think what we're getting to is, could we improve the joint environment? And what we're after today is really improving the function of the synovial membrane, the joint capsule. There are things that we can do to the cartilage, but that tends to be very slow in response. We do see a regeneration of cartilage, but really the true impact that we can get is the health of the joint by targeting our approach to the synovial membrane and the soft tissues. And the nice thing about a stem cell in this situation is that they are a modulator. They have the ability to go into the joint, read the environment, especially if it's not an overly inflamed environment. Because if it is an overly inflamed environment, then the stem cell itself has the ability to produce those anti-inflammatory proteins, and it kind of uses its energy up doing that. Whereas what we want our cell to do is to go in and modulate the area, interact with those cells, that cell-to-cell communication, to help stimulate and modulate that repair function.
Yeah, absolutely. So the cells that we're talking about then, just for my own sort of clarification, we're talking about MSCs, which are mesenchymal stem cells.
Well, for American listeners, mesenchymal.
Yeah. So these are the cells from the mesoderm, which are multipotent. And the main functions, or the main functions that we're interested in, will be anti-inflammatory, will be immunomodulatory, and will be trophic, which basically means repair. Yeah. So the situation is, if I understand you correctly there, Greg, is that these cells, they are able to respond to the milieu in which they find themselves. So the environment around the cells makes a difference to how they function. So if it's an acutely inflammatory situation, then these cells are going to behave differently. And then the secretome, the products that they produce, the cytokines and growth factors and so forth, is going to be different from maybe if it's a chronic situation or some other pathology that's going on. These cells have the ability to change their function according to where they are and what they need to do.
Absolutely. I mean, we know that, especially in a soft tissue situation, they do respond to chemokine. They will migrate to an area of damage. That's the other thing that we need to take into consideration, is that if we have an overly inflamed environment, they won't do that. They'll kind of deal with the inflammatory soup that they're now in, and they'll try and combat that. Whereas if we do have soft tissue damage, we see this in fact, Frank Barry wrote a great paper years ago on meniscal tears and the mesenchymal cell's ability to obviously migrate to that chemotactic response in the meniscus and take up residence there, not turning into tissue, but to do exactly what you said, was to stimulate. And in fact, that was one of the first papers way back in all of the journey that we've all taken in tissue engineering, that showed that the amount of tissue that was formed in that damaged meniscus was greater than the amount that was injected in volumetric terms. So this really led us in the pathway to go, this is stimulating tissue repair. This tissue would not repair without such stimulation, and it wasn't a 1-for-1, which is what we thought way back in the beginning. I put in 0.5 ml of stem cells, I'll get 0.5 cubic centimetre of tissue. Not quite the contrary. That, I suppose, when it comes to stem cells, the other big unanswered question, I don't think we'll ever get the question, is there an ideal dose? Do we get, X thousands, 100,000, millions of cells will create amount of tissue? We don't know that question. We're kind of pitching in the middle somewhere. But what we do know is that if you allow the environment to be more adaptive towards modulatory, then your dose is less of an issue. They will do the job in the tissue that they will stimulate to grow, will grow.
Yeah, absolutely. Yeah. So those MSCs, if we can call them that for short, would you recommend that we use those on their own, or is there anything that we should add in addition to those MSCs when we inject them into the joint?
Yeah, so joint is different to, say, a soft tissue tendon injury. I know the tendon injury, the work that I did with Professor Roger Smith at the RPC, we were always worried that if you had a carrier for the cells, and that's the other thing, these cells need a carrier to get there because they're quite small in volume. So the carrier vehicle was going to be one, and we used the bone marrow supernatant because it was less fibrogenic. It had less fibrogenic growth factors in it. And it was always a concern of ours that if you had something anabolically stimulating or modulating like a cell, but you had something equally trying to fight you, that would be pro-fibrogenic. You're kind of combating one against the other. But I think over the years, we've come to terms with PRP actually being quite a nice accompaniment to stem cells. We've seen some evidence that the response is good. Now, interestingly there is that there are growth factors within PRP, TGF-beta is one, that actually upregulates chemotaxis. So does that aid in the grafting and migration of the cells if those growth factors can work on damaged tissues and, say, upregulate the chemotaxis? We also have a situation where upregulating chemotaxis in damaged tissue increases circulatory cells. So you're kind of hitting it from both angles. You're going to get this migration of autogenous MSCs migrating to this area at the same time that you have this, injection of MSCs hitting both sides.
Yeah, I agree with that. And I'll add one further thing, that the fibrin that's within the PRP actually can form a clot or a scaffold.
Yes.
And MSCs, they are a kind of cell that normally occupies a niche within the body, whether it be in the bone marrow or when they're pericytes, and they're always attached to something. They like to have attachments, okay, in a three-dimensional sort of way. So when you look at an MSC under the microscope, it looks like a fibroblast. It's got multiple processes, and these processes have the ability to adhere. One of the things that distinguishes the MSCs in the lab is that they adhere to surfaces. So when you're culturing MSCs, one of the things you do when you're purifying, passaging them, is you can wash away everything else, and what you're left with on the bottom of the dish attached are your MSCs. So they've got this physical sort of predilection towards forming these attachments to surfaces. So the theory is that if you have PRP, in addition to your MSCs, and that PRP forms a clot, which is a three-dimensional network, then those MSCs can anchor and stay in the place where you put them for longer. They're going to be happier because it's more like their preferred natural environment. And that way they're probably going to perform their functions and secrete what they secrete better than if they didn't have that physical environment. It's not a chemical thing, it's a physical thing.
Absolutely.
Yeah.
Is it worth touching on autologous versus allogeneic, what is available today?
We can go there if you wish.
I think for the listeners, it's to understand that we do have the two available.
Yeah. So when we're talking about MSCs and where they come from, they can be any of the following. They can be autologous. And autologous means that the patient and the recipient is the same animal. So if you're taking, say, fat-derived MSCs from your dog and then purifying them, expanding them, and then injecting them back into the same dog, that's autologous. You can have allogeneic, in which case the process is the same, except the recipient is a different dog. Okay. We'll come to xenogeneic. This is allogeneic.
Oh, sorry.
Yeah. Okay. And third, so we don't have we do have autologous in the UK. We don't have allogeneic yet. Okay. Third, we can have xenogeneic, which means that you've got two different species involved. The target species is a different from the donor species. So we have such a product, which is dog stem, which is an equine umbilical cord MSC. So an adult MSC from the equine umbilical cord that is injected into dogs, licensed for use in dogs' joints. And there's one further one which we don't have, but we may have at some point, which is iPSC, which is an induced pluripotent cell. Is everybody familiar with iPSCs? Yeah, so this is one that has been produced by reversing the normal evolution of cells. Normally, cells start off with more stemness, and then they gradually differentiate and differentiate and differentiate down to maybe a specialized adult cell. Well, if the process is reversed, then you can get back to what is called an induced pluripotent cell. So that is also a theoretical possibility for an orthobiologic. So to try to answer your question there, Greg, we basically have two choices on MSCs. In the UK, we have autologous, in which you harvest a tissue, which is usually, in our case, adipose tissue, as our source of cells. It's not the fat cells that we're after. It's the cells around the capillaries, which are called pericytes. And we believe that pericytes and MSCs are very closely related, or they may be one and the same. Those are the cells that we take. Those are the cells that we need. That's the autologous way. And then we have this xenogeneic product, which is dog stem, which is licensed in the UK and the European Union, which is the equine umbilical cord cell. Now, the equine umbilical cord cell has a few limitations on its data sheet. Number one being that you can only inject it into the elbow and into the hip. Those are the only locations for which it's licensed. So if you wanted to inject it into a carpus or a stifle, you're off label. The second limitation is that you can only use it once, according to the data sheet. So if you wanted to top up that stifle that you've injected off label in 6 to 12 months or whatever, you're also doubly off label, because you're not meant to do that according to the data sheet. Now, it's not really logical, because if it works in a hip, it should work in a stifle, it should work in a hock, it should work anywhere, because it's the same patient. But the license does not allow you to do that legally.
Yeah, the other limitation was that if you are going to use dog stem, it should not be used in conjunction with any other intra-articular medication. Clearly that's been done because, like all pharmaceuticals, if you are going to use anything concurrent, especially in such a local environment, your clinical studies would have to show that should be done. So really what they're doing is they haven't included PRP in their clinical studies for their marketing authorization. So it's actually easier to go, do not inject with anything, so it doesn't become the status quo. So absolutely, the company behind it's basically said, look, we cannot condone the use of it. And that's where that comes from. Absolutely. Quick question on the xenogenic. Should we be worried about immune response of another species? I mean, how does that not work or work? Why can we use a xenogenic cell?
That's a great question. And when I first heard that this product was going to be released, that was my immediate thought as well. Surely, if you've got a foreign cell from a different species, then that's going to be way more immunogenic than allogeneic or even autologous. And you'd have thought that would be the case. Now, I think it comes back to the nature of MSCs, and MSCs are what we call well, there are various ways that you can articulate this, but the phrase is hypoimmunogenic. or immune privileged. So
immunologically inert.
Yes, exactly. So cells have an identity card, if you like. They have surface proteins, and we're really talking about mostly the MHC2. So if you have MHC2 on your surface, then that very readily identifies you as foreign. Okay, so if you were to inject a cell into a joint and it had an MHC2, then the innate immune system would detect that immediately and eliminate the cell. If you don't have that MHC2, then that allows you as an invading cell to go under the radar undetected, and you don't get cleaned up immediately by the immune system. So I think it's not to do with so much that it's a different species. I think it's to do with that those cell surface markers are absent. And it doesn't seem to matter which species you come from. I'm doing a study on cancer in Singapore where we're actually using cells to treat cancer in dogs, and the cells we're using are human cells. So also xenogeneic. So I think that would be my answer. And it's been through the regulations, it's been through the VMD, it's got its license. So it doesn't seem to have that risk of immunogenicity.
Yeah. So how can you help as an oral clinician decide when would you use an allo over autologous, making that decision? What's your decision pathway on that?
That's a very good question. Okay. So let's look at both then. So if you've got... if you're dealing with autologous, then in order to do autologous stem cells, you need to have a tissue source. The usual tissue source is fatty tissue, and the usual way of collecting that is at surgery. So you need to do an operation. Most of us nowadays use falciform fat. So we do a mini laparotomy, take out the falciform fat, take that fat to the lab, aseptically, obviously. Then once the lab has done all the clever stuff, then we get the cells back, and then under sedation, we inject the joint maybe a month later. So that's a two-stage process. So you need to have an anesthetic. You need to collect the tissue. So there is an upside, because once you've collected the tissue and extracted and purified and expanded those cells, they can be cryobanked. So you can have a supply for the future and maybe for the rest of the dog's life. Okay, so you can have multiple top-ups available. So it's got disadvantages and advantages. So if you've got an animal who's young enough and fit enough and healthy enough to have a general anesthetic, then doing autologous makes sense, and it's kind of future-proofed, because then you're collecting more cells for the future and banking them. Plus, it doesn't matter which joints you inject them into, or which muscles or tendons or wherever you inject them, doesn't matter. And it doesn't matter how many joints. So if you've got 3 or 4 joints affected, you can get enough cells to do all of that and repeat that multiple times. So that makes for a very nice way of doing your orthobiologic, because of all of those, with obviously the limitation that it's expensive and it needs surgery.
So I suppose in the field of disease management, we know that this is not a treatment that's going to eradicate the disease. Mm-hmm. You know, if we go into the joint with a stem cell, there will come a point in time we're going to need to go back in again.
Exactly. So
you're kind of lining that patient up for its future treatments.
Absolutely. Which makes it a very attractive way to go.
Yeah.
Okay. So what are the advantages of having the equine umbilical cord orthobiologic? Well, firstly, you don't need to do an operation, because the cells have already been produced, and you can buy the cells in a vial. Okay, they're off the shelf. We say off the shelf, they're out of the fridge, and they last about a week or 2 in your fridge. So you have to order them specifically for each patient. But once you've got them in your fridge, then you can sedate your patient and inject either an elbow or a hip. So it has that advantage, not more than once. So there's the big downside. It's not more than once, and it's only an elbow or a hip. Or I'm never sure whether it's just because you can only do it on one occasion. Does that mean that if you had an elbow and a hip, or 2 elbows and 2 hips, could you inject both at the same time? I'm guessing you could. but it has that downside. So let's say you had an elderly patient and the owner was dead against general anesthesia, but wanted a quick orthobiologic, would accept sedation, and it was an elbow or a hip, then that's where that product would be ideal. If you've got more joints affected, you've got a younger patient, they can have an operation, and you want to future-proof by cryobanking, then I would go autologous.
Yeah.
Thanks for tuning in to the Nupsala Podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala Podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media where we always post when a new episode launches. All the links and details are in the bio. Thank you!